Are you working on research you're excited to share? The 2026 NEI Fall Congress Scientific Poster Session is your opportunity to present your work on a national stage alongside leaders in psychiatry and mental health. The deadline to submit your abstract is August 3rd, 2026. Don't miss the opportunity to connect with leading experts from around the world, share your cutting-edge findings, and elevate your professional impact. Go to nei.global/fall posters to learn more and to submit.
In this episode, we're revisiting a previous conversation that offers valuable insights still highly relevant today. Whether you're hearing it for the first time or revisiting it for a refresher, we hope you enjoy this discussion and come away with practical takeaways to enhance your clinical practice.
In this episode of the NEI podcast, we are discussing a very exciting topic, and I have here with me today Dr. Thomas Schwartz. Welcome, Dr. Schwartz.
Great. Thanks for having me out today.
Thank you so much. What are the most common mistakes in psychopharmacology, and where would clinicians benefit from improvement in these areas?
I think the number one mistake is when we forget to refill our patients' medications and they get mad at us. But that's an easy one. We treat hundreds of patients, take hundreds of phone calls. So there's lots of logistical things. And we make mistakes like that. We apologize to our patients when we get their medicines refilled. But outside of that, I think sometimes we dose the wrong medicine for the wrong condition. We just assume that maybe every SSRI is equal in treating things. I think we dose drugs too low and then we don't see the outcomes or the effect we want. Sometimes we push medications too high or mix too many medicines together and create a lot of side effects. They're common everyday things because we're doing these things every day with our patients.
Why would you say diagnosis is so important? Why are many clinicians ambivalent about diagnosis?
Well, let me handle the second part. Why are clinicians ambivalent about making a diagnosis? Sometimes we see a patient and we really don't know. So sometimes we really don't know. We don't have enough information. We couldn't get enough read on the patient in front of us. We couldn't get access to their old records or talk to their therapist. So sometimes there's a real reason not to make a diagnosis. Other times we move too quickly. Let's just be candid. This talk is full of clinicians being candid. We move too quickly. We don't have time to ask all the questions we want. Maybe we had a double book and we cut corners and we just didn't have enough information. Sometimes we're just not really good at the DSM-5. And I'm not saying the DSM-5 is perfect, but it sets the framework of how all the research studies work on the psychotropic medications we prescribe benefit from. So if you don't make a good bipolar 1 depression diagnosis, how do you know a bipolar 1 antidepressant is really going to help your patient? Because the research studies are all based a bit more on meticulous diagnostic practices. So I think there's a link that we somehow have to consider it a basic strategy to be as thorough as we can, make the best diagnosis that we can. And based on that absolute best diagnosis, there's only a certain number of medicines that have been shown to be effective for that diagnosis. So I think accuracy is important. I'm not saying I'm a perfect diagnostician. I've certainly made mistakes, but you need to do the best you can, declare the diagnosis, and then think through what medications have really shown they can be helpful. And so I do think diagnosis drives everything that happens after with your prescribing practice.
Should clinicians be more aware of a potential misdiagnosis from a previous provider when they start seeing a new patient? What are some of the best ways to screen for this?
So one thing I teach my residents and my trainees is that even if I do the diagnosis in the emergency room the night before, they have to do their own new evaluation. Don't trust me. So that sounds terrible. So I'm a professor and I'm teaching everybody stuff. But at the end of the day, when you see somebody for the first time, you're their new doctor. You're the one in charge. And the person before you may not have been perfect, or maybe they were having a bad day. I teach never trust the previous clinician's diagnosis. Most of the time they're right. But every now and then they had a bad day. The patient didn't give them all the information and they've made a misdiagnosis. And if you misdiagnose somebody, again, let's say bipolar type 1, you've now committed them to a lifelong of medicines with serious side effects.
Right.
What if they were just having an adjustment disorder? What if
Mm-hmm.
they had done some cocaine? What if they have borderline
Mm-hmm.
personality?
Right. Right.
Are different, and maybe we'll be doing more psychotherapy and less medication with some of those. So I think it was the X-Files show years ago. It said, "Trust no one." I'll use that moniker. So I think when you see somebody new, don't trust the previous diagnosis. Do your own evaluation. Because what I see time and time again is in progress notes, history of bipolar, history of schizoaffective disorder, and that just takes on a history of borderline personality, and it lives in the chart forever. And somewhere somebody is rushed and they go, okay, and they just continue the diagnosis without making a thorough investigation, let's say. And then the
Right.
patient, again, wrong diagnosis, wrong meds, you don't get the outcomes that you want.
Mm-hmm. Mm-hmm. What are your thoughts about changing a diagnosis over the course of treatment?
Yeah, this is how I get myself out of trouble. So in your previous questions, I said, geez, you need to be accurate and be perfect the first time. But again, we all make mistakes. And so I do think when you see a person for that first meeting, you have one data point. 3, 4, 5 sessions later, 12 sessions later, 80 sessions later, you've got 80 data points. And I think many of us, we maybe originally felt a person was borderline personality disorder. And we felt the kind of hypomania spells were just mood lability from the personality disorder. But then you really catch somebody in a sustained 4-day, 8-day, 10-day hypomanic spell, and you've made a mistake. So I think it's okay to admit you're wrong. I have these discussions with patients where I'll tell them, again, 12 sessions, 80 sessions later, I think I goofed. I think you do have a bipolar type 2. This changes our strategy a little bit. So I'm sorry I missed the diagnosis earlier, but I think being accurate now opens a couple new doors of how we can treat you better. So I do think changing diagnosis is important. You put it in your progress note. And you put down your rationale of why you're changing the diagnosis.
Can you share a challenging case with us where you struggled over a diagnosis? How did you end up managing it?
This piggybacks really well on the comment I just made. So a patient I remember seeing had a history of post-traumatic stress disorder from her childhood and teenage years. She was probably in her late 20s when I started seeing her. So I knew there was a trauma background. And I felt she had borderline personality disorder. She met the DSM criteria, and I do think it's sadly common, a mixture of PTSD and borderline personality disorder.
Mhm.
And was working with her mostly in the medication management area. Pretty good relationship with the therapist. The therapist is seeing her weekly. We were all on the same page. And I remember for at least a few years, the patient coming in, I'm manic again, and I didn't see it in session. The therapist didn't
Mhm.
necessarily see it, wasn't meeting the mania criteria, maybe meeting hypomania, but I
Mhm.
think we chalk that up to a mood lability from
Mhm.
her personality and maybe distress from trauma and hyperarousal from PTSD.
Mhm.
And this went on, and I remember having very good academic discussions with the patient about why I felt it wasn't a bipolar disorder. And then it was a few years later. I remember I could usually talk her out of her mania, which is strange because
Mhm.
mania is not something you talk people out of. So that's why I
Mhm.
felt it was
Mhm.
more anxiety driven. But then I met her that fateful day where I couldn't talk her out of her hypomania and called the therapist who had the same experience earlier that week. I brought her back a week later, and she was still in that same
Oh, wow.
hyperactive, mood elevated,
Yeah.
no drugs in her system, no PTSD flare ups, and 10, 12 days of sustained
Wow.
mood elevation.
Mhm.
And it was just the previous times I'd seen her, it was never sustained. And it took
Mhm.
3 years, 4 years for me to be in a room with her a couple times in a row, overlapping with a therapist to go, now I see what she's talking about.
Right.
And so on that end, took a bunch of time, but then now I think she had 3 diagnoses, right? She
Mhm.
clearly had PTSD. She
Mhm.
clearly had the borderline personality symptoms from the DSM-5, and probably bipolar 2. And a
Mhm.
lot of the medicines we use are similar in
Mhm.
borderline
Mhm.
personality and bipolar disorder, but I think it was validating for her to hear that maybe she was right all along, which
Mhm.
helps,
Mhm.
but we
Mhm.
could be more aggressive with the mood stabilizers and again, we started getting better outcomes. Things weren't
Right.
perfect, but we did better. So that was a challenging case, and I do think that's common when you see trauma, personality traits, and possible bipolarity.
Hmm.
And a lot of patients have addiction on top of that. So in my world, that's the four overlapping conditions that make diagnosis very difficult.
Wow. Wow. Thank you for sharing that with us.
Are you looking to stay current in psychopharmacology without falling behind? Well, NEI membership gives you on-demand access to expert-led education, practical clinical tools, and resources you can use right away. From master psychopharmacology content to patient education materials and CME opportunities, it's all in one place. Join thousands of clinicians who rely on NEI to sharpen their skills and improve patient care. Learn more at neiglobal.com.
What common mistakes are made when it comes to dosing with medications? I know you touched on that a little bit. How can providers avoid some of these mistakes?
So outside of making a diagnosis, dosing is one of the most important things. Every drug that we use has gone through, and what all these end up showing us is that certain lower doses just don't work. They don't beat a placebo or a sugar pill. So unfortunately, I see some psychiatrists, psychiatric nurse practitioners do this. I see this more often in primary care where a drug is started like an antidepressant. Let's just use sertraline at this point. And the dose is 25 milligrams, and it doesn't beat a placebo until 50. And for some reason, there's underdosing the patient is safer, it has less side effects. But if you never get to that critical minimum therapeutic dose of 50, it's probably not going to work. And then
Right.
the dose range of that product is 50 to 200 milligrams. And some people need 100, some need 200. But every now and then I'll see somebody will be on that 50 milligram dose, which works for some people for a year or 3 years, and it's never escalated. And I'm not sure the SSRI antidepressants have a great dose response curve, meaning that going from a low to a bigger dose will help. But
Hmm.
many of our SNRIs do. Our SPARI drugs seem to have a dose response curve. And so some drugs, it is more critical to get to that minimum dose that beats a sugar pill, wait a few
Right.
weeks, move it to the middle dose, wait a few weeks. So we need appropriate dose escalation. So one of the biggest error I see is people dose things too low for too long. They're not appropriately aggressive going through the whole dosing range.
Right.
And flip side, some people overdose things. If you take a medicine like fluoxetine or Prozac, also an SSRI, you need to get to 20 milligrams to make it work for depression, let's say. And it caps out around 60 milligrams for depression, 80 for OCD, but I'll see some patients around 120. 140. And now you're getting into more side effects, serotonin syndrome risks. So it's a double-edged sword. But I
Hmm.
would love to see people be more meticulous, make an accurate diagnosis, or at least stake your claim on one, get the dose to minimum therapeutic, wait a few weeks, escalate to the middle dose, escalate to the fullest dose allowed by the FDA. Go through the full course, and then you can say it's a full therapeutic trial. And if it works, that's great. If it didn't work, you can rest assured it was never going to work, and then you can
Hmm.
medicate.
Let's turn to something a little bit different. How common are malpractice cases in psychiatry?
So it's interesting. It wasn't going to be a main theme about the talk that I'm
Hmm.
going to give coming up here at the Congress, but people have asked about things like this. Will I get in trouble if I dose something this way or use this medication? What's my legal risk? And so that was echoing in the back of my head. So we'll
Hmm.
touch on a few of these things. So the good news, to answer your question, is lawsuits in psychiatry are pretty low. So none of us like to be in a lawsuit. I've read a statistic somewhere once every decade or so we can expect to have a lawsuit in psychiatry, but our malpractice premiums are one of the lowest in the medical field, and that's because we tend to get sued the least. However, when we get sued, it's usually pretty bad.
Hmm.
Typically, a patient will commit suicide and
Right.
then will be sued by a relative. And that's crummy because even if we did the best we could, provided the standard of care better, there's still a pretty good chance of getting sued. But
Wow.
certainly, if you're negligent, not providing a standard level of care, it seems more warranted. So lawsuits are rarer in psychiatry, but they do happen.
What are some of the causes of malpractice within psychiatry?
So my data is a little bit old, but I'll never remember a lecture I sat in maybe 15 years ago. And the top three lawsuits at that time had to do with one thing that I mentioned is essentially failure to predict suicide. And predicting suicide, we could speak hours on this. And it's, did you miss key cues and things of that nature?
Right.
Nobody expects you to be 100% perfect, but did you really just miss some major indicators? So one lawsuit is failure to predict something like that. Another lawsuit, I don't know if it's still the number two one, is psychiatrists having an affair with so sleeping with your patients, that kind of thing. And that's not a prescribing error. And that's a bad thing to do and an ethics violation, but that's a big lawsuit. And then the other one is permanent side effects. So giving somebody a movement disorder like tardive dyskinesia.
Right.
So those used to be the big three, but I think the biggest areas of concern end up being informed consent. So did you discuss with the patient, here's the drug, here's why I'm using it, here's that effectiveness data based on the diagnosis you have, and here's the side effects you can expect, the day-to-day ones and the serious ones. So failure to give informed, and then a person gets one of those horrible side effects, and now you're in trouble. So failure of informed consent with any medication, and then the other one is failure to monitor. So you can take any medicine we use, and you have to give informed consent, and you have to monitor. So certainly the levels of those differ based on whichever medicine it is. So those are the biggest lawsuits now. It's bad informed consent and poor monitoring.
Okay. And what are some ways in which clinicians can avoid malpractice lawsuits? What are some pointers or some tips?
Yeah, one is never make a mistake, but we're all human. So I think you need to do the best you can, have the patient's best interest in mind. And I think most people in the field are good-hearted people, and that's at the core of it. Good diagnosis, good dosing, using the right med that's been researched and studied before you really go out on a limb with medicines. If you're going to superdose, use medicines in a big dosing strategy, you're going to combine many medications together, and make sure you have those discussions with patients. So the biggest way to avoid a lawsuit is do really good informed consent. And that takes time. You might have to have a 5 or 6 minute conversation instead of a 12-second one. So you really want to have a good conversation about the risks and the benefits and why you're doing what you're doing, and then put it in your progress note. So the number one way to avoid lawsuits is having a good discussion with your patient and document.
What specifically relates to prescribing when it comes to malpractice? You shared a little bit about that in terms of dosing. Are there any other areas that come to mind when you think of malpractice related to prescribing issues?
I think so. And again, the more you get off the beaten path, you're using big doses from that level. I call that super dosing. And some patients need that. They metabolize drugs very quickly, but you would explain that in your note. Other patients just seem to need bigger doses, but bigger doses tend to come with more side effects. Combining drugs, we've gotten very good at that. And I like Dr. Stahl's use of the term rational polypharmacy. Mixing these three drugs together, because the chemistries I'm manipulating will be complementary instead of redundant. And that tends to do things, I'll steal more of his ideas, you get in a win-win situation. You're combining neurochemistries to get better effectiveness and, let's say, lower depression. But you can also mix drugs together to get rid of side effects. So you get better good effects and you lessen your side effects. It's a win-win combination. But sometimes we're adding 3 medicines, 4 medicines, 7 medicines, and we don't always have a good rationale. Why am I doing that? The patient asked for one med. They said they had a family history on the other. I had them on 4 previous meds, but I forgot to take away 2 medications that were failing. And some patients just collect medicine after medicine. And then more drug interactions, more additive side effects, things of that nature. And that's not very rational. And so I do think, that's an important, why are you doing what you're doing? Why is the patient on each of these medicines? Can you show that each medicine really benefited? And so I think that's an important part of prescribing.
This takes me to my last question, which is, given this whole topic, What is the best way to handle mistakes in your practice professionally? So as you said, we're all human. So when mistakes are made in psychiatry, what would be the best way to handle those?
I think the risk management field, more so now than ever with physicians, clinicians of any kind, is basically preaching own up to your mistakes and apologize,
Okay.
whether it's a minor mistake or a major one. I hope all of our audience members who are clinicians, you spend time with your patients, you build rapport. All those core psychotherapy skills are important even in prescribing. Spending more minutes with your patients, having a better rapport does lower your chance of being sued. So I do think how you get along with your patients is important, and that they feel valued. And then when you make a mistake, they also know they're human and they make mistakes too. You apologize. Today, I forgot to send a refill in this morning, and I apologize for getting it at 3 o'clock. And the patient's no problems, no worries. But if I got defensive and if I said I was too busy and they think they're my only patient, they're going to get mad and angry. And if they have a bad outcome somewhere, they're more likely to sue me.
Mhm.
So you just own up to it. And that's a simple one because, again, I think we make those logistical mistakes and they're easy to apologize for. I do think, share the story of the 2 to 3 year misdiagnosis. Same thing. You have a discussion about it, own up to it. And I still have a great relationship with that patient.
Excellent. Well, thank you so much for sharing all this great information with us. And thank you for being on our show today.
Great. Thanks. I enjoyed being here.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.